And I appreciate it, as always, the opportunity to come and present information on the SDAC, and I feel kind of my role in all of this and representing the SDAC is kind of sing the same refrain to the song and reminding folks of all the information that you all have access to that in some ways is kind of the foundation of what Tracy's going to talk about in terms of their work in using clinical risk groups, which really is the foundation in terms of the risk adjustment tools that we've incorporated into the SDAC to give folks an opportunity, while not at the level of sophistication that Tracy and Paul mentioned earlier in terms of stratifying your patients, but it is really an effort to give folks kind of a starting point in terms of which patients, based on their clinical characteristics and their illness burden, folks should maybe start to focus a little bit more attention on in terms of those that might be impacting program performance, and from a care management perspective might provide some opportunities from an outreach perspective to intervene and put some practices in place to that ultimately will lead to improvement in performance and reduction in those 3 KPIs that the program is tracking: the all-cause readmissions, ER visits, high-cost imaging services, and soon-to-be well child visits. So what we're looking at here, again, for purposes of the demo, we're just looking at screenshots, but if you envision kind of the dashboard protocol, and if we go to the next slide, if you think about the left-hand side again, it's kind of split into 2 different categories, where the first view is kind of understanding what your performance is, right? So if you log in and you see as a PCMP for those respective 3 key performance indicators, am I performing above or below what my expected performance is, again, and that's risk adjusted to my specific population using clinical risk groups. So understanding program performance to give us a starting point. So for example, if I wanted to know more in this particular slide, those patients that would be impacting my overall budget performance, I would want to start to drill in there to better understand which members have services at more so than others that are ultimately driving that program performance. If we go to the next slide, that's where we start to get into the different areas that you can drill into your population to kind of understand what the performance is relative to those different indicators. So if I'm looking on the left-hand side and we're using potentially preventable events as an example, just at a quick glance I can see if I'm performing above or below expected. Obviously I'd want to spend more time on those measures where I'm above expected, because that's where there might be opportunity to improve. And having an understanding of where I'm above expected, that's where we can pivot over to the population data, which provides you member level detail on the people that are attributed to your PCMP, to your RICO, and the reports provide some detail around the clinical risk group categorization, as well as the CRG weights that indicate what their relative illness burden weight is, along with some of those counts for those key performance indicators. So I can see things like the number of ER visits that occurred for that previous 12-month time period, or the number of all-cause readmissions that occurred for that particular patient. And what we do with the population data, again, is the basis is segmenting the population using those clinical risk groups. So you have the ability, using that all members link, to download an entire report for your entire universe, if you will. But what we've typically seen in the Colorado data set and other data sets that we work with, and it makes sense, is that the old 80-20 rule, and that 20% of your population will be driving 80% of your performance. So it's going to be those patients with multiple chronic conditions that ultimately are driving the overall utilization and total cost of care and key performance indicator performance for that relative organization. And by segmenting out the population and giving you links to generate those Excel reports based on those different clinical categories, from healthy all the way down to critical, that's kind of your starting point in terms of segmenting out your population. So rather than trying to focus in on all 254,000 people, in this particular example, we can click directly on that complex chronic link, for example, and just focus in on those people as a starting point, and then from that point forward, begin to segment just that subset population into more granular detail to create a specific targeted list of, say, top 10, 20, top 10, top 20, or top 50 people within that subset of patients. So this is just an example of the types of data that's included in those patient lists. So again, using the links on the dashboard page generates those Excel files. Users have the ability to refine the Excel files like you would any other file. And one of the fields that's not represented here that I believe Tracy will talk a little bit more about in just a minute are the base CRG categories. So having that granular level of detail for that individual base CRG category, which rolls up into these broader base categories, the takeaway there is that you have that lowest level of detail as you start to click through the data within the dashboard. And then finally, in addition to the Excel reports, the concept of using the patient profiler gives you the ability to do specific case or person reviews, if you will. So rather than having the ability to look at the entire population using the population reports in the Excel files, perhaps there's one particular individual that really catches your attention in terms of ER utilization or just overall total cost of care. The patient profiler and using the member list links that are associated with each one of those key performance indicators gives users the ability to click directly on those links and pull up a list of clients that have a direct impact on the performance for those indicators. So if I were to go through kind of a high-level review, we would be able to click on the link and then see the population profile appear, which then gives you the claim level detail for that individual across each one of those different categories of service. So I have the ability to identify inpatient, outpatient, professional, and pharmacy utilization for that individual for that entire 12-month time period. So I can start to look for different trends in terms of any particular facility that particular client is utilizing more often than others. If there are emergency room facilities that appear more so than others. And some of the feedback that we've received in terms of the detail around the pharmacy, we can start to identify if there's any trends from a prescription perspective, especially around things like behavioral health and pain medication that might provide some additional insight into the utilization patterns for that particular patient. And really this chart was intended to kind of be a lead-in to Tracy's material. It provides the level of granularity that the clinical risk groups, which is the DREAM tool that we utilize to risk adjust the population. So taking into account all the claims history associated with the patient, all the inpatient, outpatient, professional, and pharmacy claims. Grouper takes all that information into account as well as some other patient-specific characteristics to assign a CRG category. Lots of specificity here. Within each base CRG, there's varying levels of severity to provide as granular as possible representation of what that the clinical characteristics for that person is. But at the same time, we have the ability to roll the granular categories into the higher aggregated groups, which is what's displayed on the dashboard, to again, with the intent being giving users a starting point to kind of segment their population